Welcome to the Brain Matters webinar. I'm Dick Moberg, your host for today's presentation. Our featured guest is Dr. Thomas Heldt from MIT. As usual, we will cover some meeting dates and abstract deadlines to give those stragglers time to get their coffee and get to the webinar site. We'll then have our featured presentation followed by a Q&A period. So let's look at some upcoming meetings. Details for all of these are on our website, www.moberg.com. Neuroscience Convergence is next week in St. Thomas. The annual Resuscitation Science meeting is in our hometown of Philly in 2 weeks. The same week as Medica in Dusseldorf, mostly a business-to-business meeting, but with a lot of cool stuff. AES is in early December, as always, for you epilepsy folks. ANIM is the German Neurocritical Care Society meeting, this year in Karlsruhe. And the One Conference on Neonatal Neuro ICU Nursing is in Orlando. This meeting has some great content on neonatal brain monitoring and is run by our friend Kathy Sally Randall. And now a few abstract deadlines. Here are some deadlines. I won't read them. Check them out on the recording of this webinar, which will be on our website in about a week. This is a good time to remind you about our newsletter, the Neuroscience Monitor, which will keep you up to date in neuromonitoring. Your colleagues can sign up anytime on our website. If you have an event or news item related to neuromonitoring and neurocritical care, please send it to us. As many of you know, I'm a meeting groupie and I love airplane food. I travel the world and meet interesting clinicians, academics, and those from industry who are helping to change neurocritical care for the better. My weekly podcast shares stories from this network of friends in a fun and informative style. So check it out. And if you have a topic of interest, please let me know. And now I'm pleased to roll a video presentation of our featured speaker, followed by a live Q&A session. Please be sure to enter your questions using the Q&A tab on your Zoom window.
My name is Thomas Heldt. I'm an associate professor of electrical and biomedical engineering here at MIT with the Department of Electrical Engineering and Computer Science, the Research Lab of Electronics, and the Institute for Medical Engineering and Science. My group is the Integrative Neuromonitoring and Critical Care Informatics group, and we are really interested in developing novel approaches that allow us to understand the physiology of the injured brain. And these approaches could be hardware development, like new devices, medical device technology, or algorithmic approaches, new algorithms to estimate important parameters of brain health. We are here situated on the MIT campus within the Institute for Medical Engineering and Science, where we have a lot of collaborations with local hospitals, Massachusetts General Hospital, Boston Medical Center, Boston Children's Hospital, Beth Israel Deaconess Medical Center here in Boston. And essentially all projects in my group have a clinical component where my students tend to be engineering students, spend some time in the hospital with our clinical collaborators, either to understand the clinical environment and understand the problems that they're trying to help solve or address, or to engage concretely in data collection for their thesis projects, for our research projects over here. So we work very closely with our clinical colleagues in the Boston area, but also across the world to address some of the problems and some of the challenges that are seen in mostly high acuity clinical environments such as neurocritical care, but also in other environments such as emergency care for adults, pediatric patients. Most of my work, certainly my doctoral work, was on the cardiovascular side. We tried to understand cardiovascular dynamics through simulation modeling approaches. Much of my interest in the neurovascular and the neural space side was kindled through a collaboration with Dr. Audrey Duplessis, who was at the time here at Boston Children's Hospital. Great friend and mentor, who subsequently moved to Children's National Medical Center to become the new chair of transitional medicine at CNMC. Working with Audrey and collecting data at the bedside of preterm neonates, we got aware of the work that Dick Moberg was doing in collecting data from different bedside monitoring devices, still an open area And his work there was really allowed us to collect data from a variety of bedside monitoring devices. And when Adri left for Washington, D.C., I inherited some of his equipment. And among other things, I inherited the very first component neural monitoring system that Dick ever built, I think. At least it has the serial number 001. And so it's a precious piece of equipment that we have in the lab, and kind of proud of having the first one. So thank you, Dick, for making that available to us, and it has been serving our purposes very well for many years now. So I now will go to the presentation where I'll highlight some of the work that we're doing here in non-invasive intracranial pressure estimation. So my name is Thomas Heldt. I'm an associate professor of electrical and biomedical engineering at the Institute for Medical Engineering and Science and the Department of Electrical Engineering and Computer Science at MIT, where I also lead the Integrative Neuromonitoring and Critical Care Informatics group in EECS, in IMES, and the Research Laboratory of Electronics. So I'll get started with the presentation. Today's topic is on non-invasive intracranial pressure monitoring, which has been around for quite a while, but I want to update you on a few advances in my own group and put that work a little bit into context of what has been done in the past. So with that, let me just flash up my disclosures here. Much of the work that I'm presenting today has been funded through federal grants of the U.S. National Institutes of Health, but also through companies such as Maxim Integrated Products, Philips Healthcare, and also supported through Boston Children's Hospital. Now, many of you are familiar with the kind of bedside monitoring data that you can see at your standard patient monitor in an ICU. And here we're showing 3 leads of an electrocardiogram, arterial blood pressure, pulmonary arterial pressure, and a plethysmographic waveform, as you might see in any standard patient monitor in the hospital. I usually use this trace to motivate some of the work that we're doing, because what you can see here is that the signals that you see are highly correlated, which is not surprising, that because these signals all come in some form or another from the cardiovascular system. So if we were to ask you to derive the heart rate, for example, from any of these traces, you would choose maybe lead 2 of the electrocardiogram or maybe the arterial blood pressure waveform, because these have the highest signal to noise. But much of the work in my group focuses around taking these signals and trying to infer more information and more clinically actionable information from these tracings than can be discerned just by visual inspection, which is usually done in the hospital environment. So much of the work that we're doing here is how do we take signals like these that are standard physiological waveform signals at the patient's bedside and turn them into more information than what is displayed over here. And of course, not always do these signals look as clean as the ones that I've just seen or shown. And so oftentimes, of course, we have to deal with simple issues of signal quality, making sure that the signals that we base our estimation and inference algorithms on are actually of high quality, because otherwise you might be led astray in your interpretations. In any case, so the question is, how can we take signals at the bedside and turn these signals into essentially more information than what can be discerned just by visual inspection? The topic of conversation is the cerebral space and is intracranial pressure. So from an engineering perspective, there are really 3 compartments in the cranial cavity. That's the brain tissue itself, central nervous system tissue, the cerebrospinal fluid, the CSF, and blood, what's in the vasculature and what should usually be contained within the vasculature. So these are the 3 compartments. When I talk about the intracranial pressure, what we mean is the mean intracranial pressure as measured at the foramen of Monro, and that is really the hydrostatic pressure of the CSF. Of course, the CSF space is distributed, and you could measure slightly different pressures at different anatomical locations. There's also temporal variations, but when we talk about the intracranial pressure for the purposes of this presentation, we'll talk about what would be measured at the foramen of Monro in terms of the mean intracranial pressure. averaged over a suitably large data window. Normally, as you know, ICP is somewhere between 5 and 15 millimeters of mercury. The treatment is indicated if ICP rises above 20 or 15 to 20 millimeters of mercury, depending on whether you're dealing with pediatric or adult patients. ICP monitoring is invasive, and even though this is a procedure that our neurosurgery colleagues tell us is one of the least invasive procedures that they do, for most of us this is still considered quite intrusive and invasive. And so not surprisingly, about 30 years of engineering research have focused on trying to get at intracranial pressure non-invasively, so without having to drill a hole into the skull, advancing a catheter through brain tissue into the ventricular space, as shown here with the ventricular drain. Of course, there are risks associated with that in terms of infection and in terms of damage to potential vital brain structures, inflicting contusions. These have been documented in the literature and still persist, although, of course, they scale somewhat with the degree of expertise that is locally available at the hospital. Now, there are variations around that theme. All require drilling a hole into the skull and advancing a catheter in some space within the cranial cavity, whether that's epidural, subdural, interparenchymal, subarachnoid, or advancing it all the way to the ventricular space. So the question that we've asked ourselves and others have asked themselves is, how can we actually get at this non-invasively? Why would you want to do that? Well, as pointed out in one of these review articles that I will highlight here, there are really major advantages of making intracranial pressure a cardinal cranial vital sign, as much as blood pressure, respiratory rate, temperature, heart rate, and so on are vital signs of the cardiovascular, cardiorespiratory system. First, a triage at the first point of patient contact would be enabled. That has to do, of course, with soldier and taking care of war fighters. We've heard a lot about concussive injuries. Triage could take care in the ambulance or the emergency room, where that expertise might not be available, and one might not actually want to drill a hole into someone's skull. If one has a non-invasive approach, one could have in-time and evidence-based application of therapy. Just think about how oxygen was titrated before the advent of the pulse oximeter and since. Even though the pulse oximeter might not be accurate to the nearest percentage, certainly it's accurate enough to titrate to particular oxygen saturation targets. Long-term monitoring without the risk of infection or damage to vital brain structures. And then, of course, the expansion of the patient pool for which monitoring might be beneficial. Because currently the monitoring technologies for ICP are quite invasive, we really don't know the degree to which ICP elevations contribute to mild and moderate TBI, although there are some data coming from the animal literature that there is a dose-dependent response. You know, unexplained headaches, chronic traumatic encephalopathy, as I've mentioned, liver problems, and so on. So that all of this could be expanded in cases in which we have a non-invasive approach to get at ICP accurately, robustly, and continuously. So, as I mentioned before, we're standing on quite a bit of research in this topic, and a lot of this research can be summarized as I'm doing over here, where non-invasive assessment of ICP is based on a physiologic variable that can be easily measured. Then a mapping or a relationship, mathematical relationship, is established between the physiological variable that can be measured and what is then labeled as non-invasive ICP or NICP over here. And if this mapping is stable and is universal, then you don't have to measure ICP itself, but you can measure and track these physiological variables to which you have easy access, and then derive an estimate of ICP from that mapping, from that physiological relationship and the associated the physiological variable and associated mathematical relationship. And there have been many modalities that have been studied, some of them still being studied. Ultrasound time of flight, for example, across the skull. The higher the pressure, the faster should be the propagation velocity of ultrasound in the medium. Visual evoked potentials, tympanic membrane displacement, features of extracted from MRI images, simple arterial blood pressure waveform, and then others like cerebral blood flow in a cerebral blood vessel, that could be an arterial vessel, ophthalmic artery blood flow velocity measurements, and so on. So there are many that have been explored in this kind of a general framework where a physiological variable is easily available, readily available, and this mapping needs to be established, and then base estimates of ICP on that mapping. Part of the problem with these methods is that you have to really figure out what that mapping is. And that is, mapping is dependent on having access to invasively measured ICP in particular patient cohorts, and then tweaking, calibrating, and tuning that mapping to the particular data, training data that you have, and then really making sure, also validating that mapping on patients that were not seen or that were not part of this training and calibration and parameter tweaking approach. So that's basically a supervised learning method, or a learning method more generally. And in general, the estimation performance tends to strongly depend on the richness of the underlying training data set. So the degree to which the patient that is really in front of you and lying in bed in front of you is represented in the training data. The degree to which that is the case, you might be willing to believe the mapping. But if the patient is really not represented well in this training data, then that mapping might simply not hold. And if you want to compare traumatic brain injury with hemorrhages, with hydrocephalus, with all sorts of other conditions for raised intracranial pressure, there's quite a lot of data that is needed in order to generate these mappings. Now I want to zoom in on one particular cohort of work that has been done in this place in terms of the input variables to such a mapping, and that is availability of time-aligned or time-locked measurements of the cerebral blood flow velocity measurement through, for example, or exclusively transcranial Doppler measurements of middle cerebral artery blood flow, and the arterial blood pressure waveform, usually measured on the peripheral side. And for many years, people have looked into this kind of mapping from CBFV ABP to non-invasive ICP. One of the first to do this was Bernhard Schmidt in Germany, who looked at input-output relationships. It's a particular way to identify this mapping. Pierre Murad out of Washington has looked at neural networks. People like Xiao Hu at UCSF and UCLA at the time have looked at machine learning approaches like support vector machines, and so have Corina Pupo out of Uruguay. And these methods are still under development and continued development and are still being refined. All these methods, as I mentioned in the previous slide, require training on invasively measured intracranial pressure. And so we will not further discuss these kinds of approaches, but we'll transition into an approach where we actually use the model-based approach, meaning that we're trying to capture in a mechanistic way the functional relationship that exists between the fluid spaces in the cerebrospinal space. As captured over here. If you look at the anatomical drawing on the left side, you see the vasculature, you see the CSF space, and you see the brain parenchyma surrounding the ventricular space. On the right-hand side, I will take you through what the circuit representation really represents. Now, if you imagine that you're actually you're standing at the MCA and you're looking down the blood flow into the MCA territory, the vessels and the surrounding brain tissue that surround you have a certain elasticity. And that is represented by the compliance element that is shown as C over here. This is a capacitance in the electrical engineering analog. And that, in some sense, just captures the elasticity of the large cerebral blood vessels and the surrounding brain tissue. So the transmural pressure across this is arterial blood pressure, which is the luminal pressure, minus the outside pressure, which we take here to be intracranial pressure. If you're then, again, looking down this vascular territory, you have a very complex structure, topology of branching vessels and distributed biophysical properties. And one of the parameters that are important here is the cerebrovascular resistance, or is the hydraulic resistance of blood flow, through this territory, which we represent on the right-hand side with this circuit element R here, which is the resistance. Now, from a clinical perspective, the cerebral perfusion pressure, so meaning that the blood pressure that drives flow through the vasculature, is the arterial blood pressure minus the intracranial pressure. So what you see over here on the right-hand side is that the pressure that drives flow through this resistance element is ABP, arterial blood pressure minus ICP, which is the intracranial pressure. So what is encapsulated in this circuit diagram is really the flow, pressure, arterial blood pressure, and outside pressure relationships and the biophysical properties of a major territory, such as the territory of a middle cerebral artery, but it could also be the anterior posterior cerebral artery, depending on which blood flow you're imposing here, CBF. Now, the idea here in very general terms is that this implied by this circuit representation is a mathematical representation that constrains the solutions that are possible between ABP, CBF, and ICP. But unfortunately, we do not have the benefit of having the volumetric cerebral blood flow, CBF, available at the middle cerebral artery. We do not have the arterial blood pressure available at the inlet of the middle cerebral artery. What we do have is cerebral blood flow velocity through transcranial Doppler ultrasound, as we see over here. So it's not in milliliters per second or milliliters per minute, but it's in centimeters per second. It's a velocity. And we don't have the cerebral arterial blood pressure at the level of the MCA, but we have a peripheral arterial blood pressure measurement. And there are some caveats associated with the fact that we have these surrogate measurements rather than the ones that the circuit model requires. And we've dealt with these, and I'll be happy to point anybody to our literature, our papers, or come back to these kinds of remedies that needed to be done in the question and answer session. At any rate, these are the variables that are continuously available at the bedside in a neurocritical care unit, or that can be made available like CBFE. And the general sense then is of our estimation approach is to measure the arterial blood pressure waveform, to measure in a time-locked manner the cerebral blood flow velocity waveform, and then to use the model that I've just described to estimate on a window-by-window basis, where a window can be anywhere from 20 to 60 beats worth of data from a particular patient, to estimate the model parameters, which are ICP, RNC. And these are patient-specific parameters. So the benefit that we see over here is that we really don't need population parameters or training of these individual parameters to a population. These are individualized parameters that we estimate directly from the data of a particular patient from whom this waveform data is collected. There's no learning within the patient, although we have actually explored various learning and updating approaches. And there's no calibration, meaning that we don't need to have an invasive ICP measurement to begin with in order to anchor the estimates of ICP going forward. So these are the kinds of benefits that we see, at least over some of the more machine learning based methods. Of course, the proof is in the data, and we first validated this approach back in, I think, the first paper came out around 2012, where we reached out to Marek Czosnica at Edinburgh's Hospital at the University of Cambridge, a collaborator on this work and a universal donor of the kind of data that I've just described. So we had data from 37 comatose severe TBI patients, 35 hours worth of continuous waveform data collection. Patient characteristics are shown over here. The cerebral blood flow velocity measurements were made via TCD, either unilateral or bilateral. A radial arterial blood pressure was available with an indwelling catheter, and ICP was measured with a parenchymal probe. Importantly here that Marek kindly made the CBF and radial ABP data available to us, but the ICP measurements he hid from us, meaning that they were only revealed to us post hoc after we were done with the estimation. So the early data looked like this. Here we show two examples from the paper that was published back in 2012 in Science Translational Medicine, where we have measured ICP in blue and our estimated ICP in red. And I again emphasize that we didn't have access to the blue when we did our ICP estimations here in red. What we've done on the left-hand side is that we fed 60 beats worth of data into our estimation algorithm. So that's 60 individual beats from a longer record of data. We made one estimate of mean intracranial pressure, and then we moved this data window forward by 1 beat, did another estimate of mean intracranial pressure, and we call this a sliding window approach, where the data window is sort of sliding across the data, and we get sort of a beat-by-beat update of our estimated ICP. And you see this is, as I said here, the 23-year-old male, GCS, a Glasgow Coma scale score of 7, going through a plateau wave. Of course, you also see that the ICP is quite elevated, 35 to begin with, and then going up to 60. I'm quoting here our statistics bias of 4 millimeters of mercury, standard deviation of the error of 3.2, and total root mean squared error, which integrates essentially the error across the entire waveform between the blue and the red, of about 5.1 millimeters of mercury. What is more important than the details of these statistics right now is that we actually capture the trend quite well. On the right-hand side, what we've done is slightly different. Here we've actually taken 60 beats worth of data, and then we hopped forward by 60 beats. So we didn't do the sliding window approach, we did a hopping window approach, where now each dot in red here is obtained on an independent window of 60 beats, meaning that there was no overlap with the previous 60 beats, no overlap with the following 60 beats. So I said we call this a hopping window approach. So if you were to switch this approach up on, let's say, at 20 minutes, you would get exactly that point back that is representative of the 20-minute mark over here, simply because you're not relying on any prior data that happened before or any future data that might come. Of course, here it's a very sick patient. ICP is going from 60, mean ICP going from 60 to about 100 millimeters of mercury. You only see this, of course, in subjects in whom care is withdrawn, which was the case in this particular subject over here. But you also see that as the ICP, the measured blue ICP mean ICP is trending up, our ICP estimates track this trend rather formidably. So looking at all the estimation results of the data that we had back from Marek, those were average age range the age range was 60 to 67 years, all closed-head severe TBI cases. The bias or overall error, the mean error, is acceptably small. So we have a bias of only about 1.6 millimeters of mercury and a standard deviation of the error of about 8 millimeters of mercury, which is quite a big spread. So we were quite encouraged by the data and the results that we've had. The question that arose now was, how do we take something that has a standard deviation of the error of 8 millimeters of mercury, and how can we actually shrink that down to a standard deviation of the error, ideally of about 4, maybe 3 millimeters of mercury? Because the transition zone, of course, is between 15 and 20 millimeters of mercury or 15 and 22 millimeters of mercury. This is the kind of level of ICP that we would like to resolve on a patient-by-patient basis. So it's not enough to do well on average. We have to be able to do well in the individual subjects. So for us, this boiled down to three questions. How do we improve on the initial results? Well, do we have to have a more refined model? The model, as I pointed out, is highly aggregate. Of course, the actual physiology is a lot more complex than a simple resistance and a simple capacitance element. Is it the algorithm, the way that we solve the model to get at RC or ICP, or is it actually the data quality? So we've played around with different types of models. So this is not really targeted towards an engineering audience, so I will skip over that a little bit. We also played around with the algorithm itself, developed a pre-processing pipeline. We looked into various other ways in which we solve the actual model to get at the NICP, RNC values. I'll also skip over that a little bit. I can point people to the literature on that. The piece that I do want to talk about is the data collection. The data that we got from Marek Czosnika for our 2012 paper was fundamentally enabling, but we were missing quite a bit of metadata that would have allowed us to stratify our estimation errors a little bit. So we reached out to colleagues here in the Boston area at Beth Israel Deaconess Medical Center, Boston Children's Hospital, and Boston Medical Center to collect our own data. And this is what our data collection looks like. It's this was a mock session that we did in one of the simulation rooms at Boston Children's Hospital with Robert Tasker, the chief of neurocritical care there, Carrie Laurover, member of the neurology staff, and our team here at MIT. We came in, we had our setups in terms of a couple of carts, as you see over here. We had a Spencer TCD system that you see on the right-hand side in yellow. Then on the left-hand side here, you see Dick's CNS 100 monitor that we use to collect data at a common time axis. Most of the ICU patients had an invasive line, but we also used the non-invasive arterial blood pressure measurement system, which is the NextFin system over here, just to compare and to see whether we could do our estimates on the basis of the non-invasively measured ABP waveform. Now, there is an important piece that I want to emphasize when it comes to the data collection, which will play a role towards the end of this presentation, which has to do with the fact that the arterial blood pressure is often leveled or calibrated to the level of the right atrium, to the level of the heart. Now, and then you probably also know that many patients with brain trauma are in the head-up position, meaning that there is a hydrostatic pressure difference between the level of the heart, the ABP measured at the level of the heart, and the ABP that would be measured at the level of the brain. This simply has to do with the weight of the overlying fluid column. And so if you are interested in the cerebral perfusion pressure, you would have to translate the pressure that's measured at the level of the heart to the pressure that's measured at the level of the MCA. And that's where this ρGH term comes in. So the weight of the column and the vertical distance that separates these two measurement locations. So when we came to the bedside, one thing that we did is we simply measured with a tape measure from the floor to the level of the ABP transducer. We measured that vertical distance, and we measured the vertical distance from the floor to the ICP transducer and from the floor to the tragus. So that we could, in post-analysis, could actually do this estimate of the mean arterial blood pressure at the level of the MCA, simply as the mean arterial blood pressure level measured at the level of the heart minus this ρGH column. Rho is a function of the hematocrit, so the density of blood is a function of the hematocrit. So one of the things that we also wanted to figure out is how much does this variation actually matter in our ICP estimates. Remember that we're now starting to, fight for every millimeter of mercury. So that a priori, we thought that that might actually be something that could gain us another half to a full millimeter of mercury. So at these different sites, we had different setups. We had Spencer TCDs, TCD systems from DWL and Philips, and patient monitors that were used with the Philips MP90 and the GE Solar. So we had different study personnel, different setups at each one of these locations. So to date, these are the patient statistics that we've had. In the ICU at Children's Hospital, we have 13 pediatric patients, 2 to 25 years old, with various pathologies. So far, we've collected over 44 individual studies over the greater than 10 hours of recording duration. At Beth Israel Deaconess Medical Center, we piggybacked on the standard TCD examinations for vasospasm and subarachnoid hemorrhage cases. So there we only have SAH patients. And because the stroke neurologists move around these various vessels very expeditiously, we have comparatively less amount of data at BIDMC, and we're collecting also data at Boston Medical Center, where to date we have more than 5 patients, but we'll show you just estimation results on five subjects. All patients had radial artery pressure measurements, Philips or GE patient monitors, Spencer or Philips CX50 ultrasound systems. Now, I've talked about the need for signal quality assessment. This is work that we've done a few years back now, where we do a careful signal quality assessment at the level of the arterial blood pressure waveform, at the level of the time-locked cerebral blood flow velocity measurement, and exclude any segments from our analysis that does not adhere to our standard of signal quality, so that we don't base our RC and ICP estimates on data segments that we know to be erroneous or contaminated with artifact. And that turns out to be quite important, as you will see. So, with that, where do we stand? The summary of the results are here. At Children's Hospital now we have a bias of 1 millimeter of mercury, standard deviation of the error of 5.1 with a root mean squared error of 5.2 millimeters of mercury. So we were able to shave off about 3 millimeters of mercury from the standard deviation of the error, or the root mean squared error, which might not seem much, but we're approaching the region where, the kind of resolution that you need between 15 and 22 millimeters of mercury. So Beth Israel Deaconess Medical Center, we have a magnitude of the bias of about 2 millimeters of mercury with a standard deviation of about 4, root mean squared error of 4.3, and Boston Medical Center, about 0.5 millimeters of mercury of bias, or absolute bias, and a root mean squared error of less than 4 millimeters of mercury. So if we pool all of these results, we get a bias of the method of about 0.7 millimeters of mercury, and a standard deviation of the error of 4.9 millimeters, or let's say 5 millimeters of mercury. So we are dominated, of course, by the data that we have at Children's Hospital, because that's what's contributed the most number of data points to our estimates. So not surprisingly, we come out quite close to the bias and the standard deviation of the error, root mean squared error, that we have for Children's Hospital. But we're continuing to collect data, and we are pleased that with the careful bedside data collection infrastructure that we've put in place, we've been able to reduce some of the variability in the data that we have. Now, how good is good enough? We're always asked. So if we go back to the picture that I've shown before, there's quite a number of comparative studies out there in clinical populations that compared the ICP measurement through a parenchymal probe and a ventricular drain, or 2 ventricular drains in the same brain, without midline shift, so without active compartmental pressure differences. And so here I'm quoting one particular paper by Lascott, who looked at the difference between an intraparenchymal probe and a ventricular drain in a cohort of subjects. And he demonstrated that, or this paper demonstrated that, the limits of agreement, so about 1.96 or 2 times, plus or minus 2 times the standard deviation of the error, is somewhere between -8 and 7 millimeters of mercury. And these are 2 probes that are commonly being used in clinical practice. So whether you base your estimate on one or the other, you might already encounter errors that are of this order of magnitude. So when we look at this in our cohort here, the blue shaded region is the limits of agreement that I've just quoted from the Lascott paper. The dashed dotted lines are the limits of agreements of our estimates. So we're starting to approach the kind of limits of agreements that you have in sort of standard clinical practice between these 2 invasive measurement modalities. And our approach, as others, would not require necessarily would not require the drilling of a hole, in the skull or through the skull. So what if we analyze our results? So the baseline model is the model that I've just shown. So a bias of 0.5, 0.7 millimeters of mercury, SDE of 5 millimeters of mercury with a root mean squared error of 5 millimeters of mercury. If we don't correct for the hematocrit, the density dependence of the hematocrit, these performance metrics essentially don't change. Whether you're 0.5 or 0.8, there's nothing that is statistically significant here. So what we were able to show is that really taking care of the hematocrit correction for the blood density doesn't really change anything, at least over the range that we've seen in our data. But if we do not correct for the rho GH pressure difference between the pressure measured at the level of the heart and the pressure that our model assumes at the level of the brain, the bias jumps from less than 1 millimeter of mercury to more than 4 millimeters of mercury, with a root mean squared error of about 7 millimeters of mercury. So that's getting back into the range where we're encouraging results, but we're not quite there. And if you don't do any fine signal quality assessment and artifact rejection, your bias goes up to about 3 millimeters of mercury, but your root mean squared error is about 10 millimeters of mercury, which means that your 95 limits of agreement are about plus or minus 20 millimeters of mercury, which is clearly unacceptable from a clinical perspective. So I want to take this moment to say that the sins that you commit at the time of data collection are difficult to impossible to correct in post-processing. So when you set up your ICP monitors, your ventricular drains at the bedside, just make sure that, and you're trying to compute cerebral perfusion pressure, make sure that you take care of the hydrostatic correction that exists between pressure measured at the level of the heart and pressure, as measured at the level of the brain, if there's a vertical distance between those that might be significant. Also, of course, if you have garbage in, you have garbage out, and so you shouldn't base any of your decisions, of course, on data that are overtly artifactual. So I hope this gives you a summary of where we stand with our model-based approach of non-invasive intracranial pressure estimation. As I mentioned, there are many learning-based methods out there that are still that are still being pursued and pushed forward. Machine learning-based methods. And I would encourage you to also keep your eyes open to those developments. It is still an active field and it's an exciting field, but I think with advancements in sensor technology, both on the arterial blood pressure and the cerebral blood flow velocity side, and by accounting for some of the variability and controlling for some of the variability at the time of data collection, I think we're getting close to clinical significance of the results, putting devices together that can be then put into the hands of clinicians to be tested alongside measurements in sort of a blinded or multi-center kind of approach. So with that, let me just thank the people here at MIT, students and colleagues, as well as our collaborators at Beth Israel Deaconess Medical Center, Children's Hospital Boston, and Boston Medical Center. Without their help, we would have not been able to, of course, do this work, and of course, always thank our sponsors who've made all of this possible. And with that, I'd be happy to take your questions. Thank you very much.
Thank you, Thomas. So everybody, please get your questions entered using the Q&A tab. We'll then go live to Dr. Heldt in about 2 minutes. But in this short segment, I want to tell you about an exciting project that is just getting started here. A group of collaborators is attempting to create a new medical record for the brain. Most of us realize the shortcomings of the current metrics recorded for the brain and realize we need a more immediate and comprehensive view of brain status to enable precision management. Our project is to define what the new record is and the technology needed to make it happen. The key to a more meaningful medical record is better access to data and better quality of data. There have been many efforts aimed at this for decades. We were funded in 1996 by NIH to investigate architectures for multimodal monitoring. IMEDS was formed at Draper Labs right next to MIT by Len Polizzato about 10 years ago, and this morphed into the Working Group on Neurocritical Care Informatics, which first met in 2015. The working group just received funding from the Department of Defense to support its efforts for the next 3 years. To enable multi-center collection of data for use in big data applications, terminology needs to be standardized. An initial project has been to develop a gap analysis of terms used in neurocritical care versus terms that are defined by one of the standards organizations like LOINC, IEEE, or SNOMED. One of our first efforts is to work with a group of collaborators to develop standardized definitions for these gap terms and submit them to the standards organizations. Another effort is to develop standardized interfaces that promote the interoperability of data. And we'll be working on this architecture as well as part of this project. We're creating a consortium of organizations, industry representatives, and collaborators to help solve these problems. Join us by sending an email to info@smartneuroicu.org. So thank you. And now we'll go live to MIT to join Dr. Heldt for questions.
So thank you very much for your attention, and thanks, Dick, for facilitating this this podcast or webcast. And thank you for your questions. So let me take these questions in reverse chronological order as they come in. So one comment here says, in summary of your results, most patients was without intracranial hypertension. It is indeed true that most of our data is has its mass located between 5 and 20 millimeters of mercury. We have some data records that go up to about 37 millimeters of mercury. That is related to the fact that we have a need for consent. So particularly in brain trauma patients, it's difficult to come to the bedside, get consent from the patient or the next of kin, the legally authorized representative, and time to actually capture the initial high phase of ICP. By the time that we can get to the bedside for the data recording, usually the neurocritical care staff does what they are supposed to do, and what they do best is namely to stabilize the patient and to bring the ICP down. We have started to supplement our clinical recordings with animal studies here at MIT that are not part of this presentation, but in the animal studies, we're taking the ICP up to about 60 or 70 millimeters of mercury. So we span the whole range of what one could see physiologically, pathologically, and in the extreme values. And our initial indications are that these estimation approaches hold up over a much wider range of ICP than we've seen over here in the clinical data. We're also trying to actually get to the bedside earlier, so we're working with our clinical colleagues to call us in when there are hypertensive crises so that we can capture these as well. Another question related to transcranial Doppler monitoring 24/7. It seems that that would be needed for our work. If you want to have a truly continuous measurement of non-invasive ICP on the basis of the technologies that I've described, then yes, that would be true. But there are colleagues here at MIT and elsewhere that are working on autonomous transcranial Doppler ultrasound systems that could be either strapped on or that could just be placed near the temple region. And what you could do is you could monitor, every 15 minutes for a minute and see whether ICP is rising or ICP is high, and then you could actually switch on a more continuous mode of transcranial Doppler measurement. So the way that I envision this is that, first of all, the transcranial Doppler part needs to become operator independent. And as I said, there's exciting work both in startup companies, but also in larger companies and in academia that addresses this piece, namely the autonomous collection of transcranial Doppler ultrasound systems. Or cerebral blood flow velocity measurements, and then take that to the bedside and do spot measurements. And when the ICP is high or is rising, that then you could go into a continuous mode to then monitor over longer periods of time. Of course, 24/7 is a lot, and one would have to consider the implications with tissue heating of having ultrasound insonation for that long. But that's not the model that we're going after here. What unit is the height measurement in? So we measure the height, the floor to the transducers in centimeters, simply because centimeters and millimeters, because this gives us a finer resolution than if you're to a fraction of an inch. But in the end, you convert it to whatever unit is necessary to convert rho GH into a millimeter of mercury unit. But we actually use a simple tape measure like construction workers have. It's just that it's in centimeters and millimeters when we measure from the floor to the height of the transducers. So that's the answer to that one. There's a question that there's any significance in the bias between Children's Hospital, which had a positive bias in our Bland-Altman analysis, and the adult data from Beth Israel Deaconess Medical Center and Boston Medical Center. We're in a fraction of a millimeter of mercury here. I don't think that there is any significance that I would ascribe to that, to those differences in numbers. So it's minus 0.4, minus 1.9, and 1.0. So it's maybe slightly larger than a fraction of a millimeter of mercury. But I think it is more likely to be related to the fact, and I've seen that at the bedside when we actually do recordings, that sometimes the transducer for the arterial blood pressure is taped close to the wrist, and sometimes the patient is posturing, or even if the patient is heavily sedated, might actually move a hand, and so that there might be changes in the vertical height that we don't capture while we're actually doing the transcranial Doppler ultrasound. So I don't think that this is something systematic. Of course, some of these sites we have limited data. I think it really has to do more with the fidelity and accuracy with which we collect the data at the bedside while we're at the bedside. The height information we take at the beginning and we take at the end. So anytime there's a change in the transducer height or the patient moves his or her head, that affects our measurements slightly. Let me jump back. Is the survival rate relative to a more developed peripheral vascular system of adults? I don't quite understand what this question is about, so maybe you want to rephrase this. I don't think that we've talked about the survival here in terms of survival of the patients. So let me jump to the beginning. How dependent are your estimates on getting the transcranial Doppler measurement of CBF just right? What is the Doppler angle is off slightly from the optimal angle? How dependent is it on the experience of the TCD tech? In our studies, we actually trained study staff. These were not trained transcranial Doppler ultrasonographer technicians. These are people that we trained, either fellows or respiratory therapists who wanted to gain some research experience. So with very limited training, we were able to actually get very good measurements from the middle cerebral arteries. Those are the arteries that we are usually targeting, or the arterial segment, so the M1 segment of the middle cerebral artery. The mathematics is in our favor here a little bit, and without digging too deeply into the mathematical details of the model, turns out that if a multiplicative relationship exists between cerebral blood flow velocity and cerebral blood flow over the course of one estimation window of about 60 beats, that the Doppler angle or the area of the vessel actually drop out in the mathematical treatment, and that's fortuitous. So I would say that as long as you have a reasonable signal-to-noise ratio of the cerebral blood flow velocity measurements, in our experience, is that the measurements are not overly sensitive on the cerebral blood flow velocity measurement, as long as it's not artifactual or overtly noisy data. Your method still needs radial arterial blood pressure, which limits its application to a large patient population. That is indeed true. We have, as I indicated in the presentation, explored using a non-invasive continuous arterial blood pressure measurement that has so far not, or commercially available measurement, that has so far not worked out for us too well, but we are working with colleagues here at MIT to see whether the arterial blood pressure waveform measurement can be obtained ultrasonically from a vessel that might be closer to the brain, for example, the carotid artery. This is work by Harry Lee and Charlie Sedini here at MIT. So we're also pushing this work forward. We would like to get away from the radial arterial blood pressure measurement, but we cannot use a simple cuff, because the cuff only gives you systolic and diastolic and mean pressure. We need the actual waveform in order to solve the model. So we can't just use the cuff in order to apply the method that I've described over here. How good is your method for triage decisions? We have, depending on the data that we're looking at and the patient cohorts, bias the results a little bit in one direction or another. We have a triage sensitivity of about, or we have a sensitivity of detecting intracranial hypertension of somewhere between 75 and 80 some %. I think in the specificity of close to 90%. Our neurocritical care or neurosurgery colleagues say this is, on the right trajectory, but we still have some way to go. They would like to see both the sensitivity and the specificity, in the mid 90% range or above. But keep in mind that we would not have to drill a hole into the skull, and we could do repeat measurements over time to see whether there are trends in the mean ICP estimates. So we're continuously refining the algorithms, and with more data, I hope that we can actually push that into the range where the clinical colleagues are happy. When do I think that a non-invasive ICP measurement will be available routinely at the bedside? Well, I think that's the big question. From the technological perspective, I think we have, and others have de-risked the actual engineering aspects sufficiently, or at least we know where the bottlenecks are. Other aspects that flow into that decision are, of course, collaborations with industry leaders on developing things like an autonomous transcranial Doppler system, potentially getting away from the invasive radial artery blood pressure measurement. And then, of course, it's the regulatory pathway. And of course, to convince clinicians like you here who are here on the call, one would have to go to multi-center clinical validation trials in a whole host of cohorts, whether it's hydrocephalus, subarachnoid hemorrhage, traumatic brain injuries, and so on. So I hope that it's not too far out. I would really hope that we would be on the path over the next 10 years. But we have to take one step at a time, and that's for us here at MIT as technologists, is to de-risk the technological developments and work with our industry partners to see how we can actually productize an approach like the one that I've described today, or other approaches that are out there. So ours is not, as I mentioned, not the only approach in that domain. So let me go back to the bottom here. Do you have data when you compare epochs with active therapy, intracranial hypertension, or without therapy? Unfortunately not, and that has to do with the fact that when there's active hypertension going on, we have to do a little bit of education of our beloved nursing staff, because as you might imagine, the nurses protect their patients quite strongly. And they, of course, want an intracranial hypertensive episode to subside before they want us to come to the bedside and do recordings on the patient. So we are in negotiations with our clinical partners to allow us at the bedside, when there are intracranial hypertensive episodes that are under management and under active management. I would love to have that data, but there is a whole procedure of coming to the bedside with 2 cards, collecting the data, hooking up to the patient monitors. And you can understand that if the patient has an active intracranial hypertensive episode, that we have to tread a little lightly to make sure that we're not stepping on anybody's toes. But we're in the process of hopefully collecting that data soon. This is a fantastic lecture. Thank you very much. Have you thought about EEG? We would love to collect EEG, and Dick's CNS monitor is, in essence, an EEG monitor. It's something that we would like to roll out, and especially when we can get to the bedside doing episodes of normal tension, intracranial normal tension, and episodes of intracranial hypertension, to then look at the electroencephalogram and to see what kind of changes are induced by the interplay between the cerebrospinal fluid space, cerebrovascular space, and the cerebrovascular neural coupling. So I would love to get to that point. We do not have that data at this point. Personally, we don't have that in terms of the transcranial Doppler ultrasonography, the radial artery measurement, the ICP measurement, and the EEG. But it's something easy to add. But any additional variable that is not routinely measured adds complexity to the study, and we are already at a level where the studies are complex when we come to the bedside, 2 to 3 people to take all of these measurements and to do it efficiently. As I said, I would like to add that measure, and hopefully soon we will be able to do that. What is your opinion about measuring non-invasive ICP by estimation velocity in the straight sinus? Do you have any experience? We personally, I don't, and our group doesn't. What our work really tries to ascertain is that there is a functional relationship between the measurements that we do make and the measurements or the variables that we would like to estimate. Hence, the cerebral blood flow velocity and the arterial blood pressure as input variables to our model, and the intracranial pressure as an estimate. And let me just elaborate a little bit on that before I answer the question. If you think of cerebral blood flow velocity as a surrogate of volumetric cerebral blood flow, and if you think of cerebral perfusion pressure as the pressure that drives blood through the vasculature of the brain, so cerebral perfusion pressure being arterial blood pressure minus intracranial pressure, implicit in the relationship of CPP to CBF or CBFV is intracranial pressure as the downstream pressure. So you can imagine, or you can at least appreciate, I think, that if you have arterial blood pressure and if you have cerebral blood flow or cerebral blood flow velocity, imprinted or implicit in that relationship is intracranial pressure as a downstream pressure. So that's why I think the method that I've presented today has a chance of working in a patient-specific manner. Now, if we only look at velocity, there might be a correlation with intracranial pressure. The higher the intracranial pressure, maybe the more constricted the straight sinus. And if cerebral blood flow stays the same, then cerebral blood flow velocity would have to go up. But there would be not exactly the same mechanistic relationship that we're leveraging here. We would be leveraging a correlation that may or may not hold given changes in other variables. So we don't have experience with that, and I'm not sure whether I would believe that such a relationship would be reasonably universal to allow application in a large cohort of patients, but I'd be happy to be shown wrong. Finally here, what about NIRS? Comparing with TCD, NIRS seems to be easier to get stable signal, especially in the pediatric ICU. I agree with that. NIRS has been around for a long time. We've experimented with NIRS in the work that we did with Professor Audrey Duplessis that I mentioned in the intro to our lecture here. And for the work that we're doing over here, NIRS doesn't have the time resolution that we need. We need the actual waveform in order to estimate the parameters of our model, and we also need the blood flow velocity or the blood flow to be identifiable or assignable to a particular vessel. NIRS provides oxyhemoglobin and deoxyhemoglobin concentrations in bulk tissue. In a small, level of the cortex. So while it does give you, under certain circumstances or under certain assumptions, information about blood flow and blood volume in the brain, it is a blood flow per volume element and blood volume per volume element of tissue. And it doesn't have the temporal resolution and the spatial resolution to be locked onto a particular vessel as we would need over here. But I do agree that that NIRS is easier to get. You can just put the optodes on the frontal part of the skull and get a signal. Unfortunately, it doesn't apply to the method that we are experimenting and evaluating here because of lack of temporal and spatial resolution. And I think I've come to the end of the questions. These were all fantastic questions. Thank you for paying attention, for asking your good questions. And I think I'll turn it back to Dick if you have any final questions. I'd be happy to make available our papers. They're also on our website, here at MIT. If you Google my name, you will very easily find our website for the Integrative Neuromonitoring and Critical Care Informatics group here in the Institute for Medical Engineering and Science. And with that, thank you very much, and I turn it back to Dick.
Thank you, Thomas, for your presentation. It was wonderful. And I also wanted to say it was great seeing our serial number 1 unit when I visited you, and it was great to know it's in such good hands. I also need to give credit to Gary Trapezzano, who is our VP of Engineering here, and it's his team that really gave birth to that baby. So also, thank you again. Thanks to all of our listeners in Europe, especially who are up late on a Friday night. And we hope to see everyone at our next webinar. Thanks again.
Thank you.